In this final section of Chapter 25 of our Human Anatomy and Physiology text, we'll be looking at a few aspects of kidney function and urinary system anatomy. First of all, we'll talk about renal clearance. Renal clearance is a very powerful strategy for assessing the health of the kidneys. Oftentimes when kidneys become diseased and aren't functioning properly, they don't allow enough filtration to happen in the glomeruli to then be able to produce urine and get rid of waste from the bodies. So glomerular filtration rate, that's the sum of the filtration rate of all the 2 or 3 million glomeruli in the two kidneys. It's a great way to find out how well the kidneys are functioning. And there's a way to figure that out, right? How could you get access to what the glomeruli are doing? Well, there's an elegant trick, namely renal clearance, to allow us to do that. So this definition is important. Renal clearance is the volume of plasma cleared of a particular substance per minute as the blood passes through the kidneys. In other words, if there's a certain concentration of a solute in the plasma, and then we pass the blood through the kidneys, if we imagine that the blood still has the same concentration as before, only now some of the plasma is missing that solute, how many mils would that be? How many mils have been stripped away of that particular solute by the processing of the kidneys? Hopefully I can explain that a little more as we go through the next few pictures. Here's how we can actually calculate renal clearance. Renal clearance for a particular substance can be calculated by looking at the concentration of that substance in the urine times the flow rate of urine, mils per minute of urine production, divided by the plasma concentration of that substance. And those are things we can order from the lab. If we have somebody in the clinical ward and we're making various analyses of their body functions, and we may be taking some blood samples and so forth, or we can just take a urine sample as well, send those off to the lab and find out what renal clearance is. How exactly can we do that? Well, in a special case, renal clearance of a substance that is filtered, right? It goes through the glomerulus along with the water, through the glomerular capillary walls, but is not reabsorbed nor secreted in the tubule at any point, then the renal clearance of that substance is equal to the glomerular filtration rate. That's the magic of renal clearance for us. Renal clearance of a substance that's filtered but not reabsorbed or secreted is equal to GFR. So we just need to get these data on a substance like that. What substance could that be? Inulin is a plant sugar, and it's foreign to the body, so there are no transporters for it. So when you inject inulin into the blood, it's a harmless substance. It's filtered in the glomerulus, but it's not reabsorbed or secreted in the kidneys, in the nephron. And so by calculating the renal clearance of that inulin that's been injected, we will now know the GFR, which is a healthy textbook value for GFR is 125 mils per minute. So our patient might have a GFR of 40 or 50 mils per minute. We'll know that that person's kidneys are not doing their job adequately. By the way, I want to warn you, inulin is not insulin. It looks similar. Insulin is a peptide hormone. It's not a polysaccharide. It's a peptide hormone produced by the pancreas when sugar rises in the blood. So let's not confuse that. Inulin is a plant sugar that's used for one sole purpose, and that is for calculating GFR through renal clearance. All right. Pretty magic. Well, it turned out there's an even easier way to figure out GFR from renal clearance. Creatinine, a metabolite of muscle creatine, always present in the plasma, is pretty much not secreted or reabsorbed. It's a little bit secreted in the nephron, but using a small correction factor of around 10%, the renal clearance of creatinine is equal to glomerular filtration rate. So since creatinine is already present in the blood, when we send away our samples to the labs, we can just ask them to measure creatinine levels and we can calculate renal clearance. So a very important clinical trick for checking out the health of the kidneys. So again, if we have a filtered solute that's not reabsorbed or secreted in the kidneys, in the nephron, renal clearance of that substance is equal to glomerular filtration rate. How about another example of a special case? If renal clearance is 0, what would that mean? It means something is completely reabsorbed, right? Glucose. If we calculate the renal clearance of glucose and we measure urine concentration times urine flow rate divided by plasma concentration, there is no glucose in the urine. So 0 times any number divided by any number, 0. So renal clearance of glucose is 0. If a renal clearance of a particular substance is less than the GFR, right, if we calculated the GFR from renal clearance of inulin, say, and then we checked a different solute, let's say we're a medicinal organic chemist and we're trying to work up a new drug, and we want to find out how well it's handled by the kidneys, how well it's retained in the blood. If the renal clearance is less than GFR, that means that substance is reabsorbed. Right? It's going to be filtered, but then we're going to take some of that back in the body. That would be perfect for a drug we're trying to develop. How about if renal clearance is greater than GFR? That means that in addition to what was filtered in the glomeruli, there's additional solute in the urine of that particular solute. I shouldn't use S for all these, right? It makes you think they're all the same. The solute just means in any given case what solute we're interested in that occasion. So anyway, renal clearance, if the renal clearance of a particular solute is greater than GFR, it means it's being secreted into the urine. So that would mean not a good thing for a new drug, right? Because we want the drug to stay in the blood and do its thing and help the body in some way. All right, chronic renal disease. We said that a lot of times when the kidneys aren't well, they're not filtering well, and that's the big problem. So if the GFR is less than 60 mils per minute for 3 months or longer, then we're talking about renal disease. So that's bad. Hypertension, we said, one of the reasons we want to manage hypertension, reduce that blood pressure, is because it will damage the kidneys and we'll have this problem and it will be permanent ultimately. Renal failure. If the GFR gets so low, below 15 mils per minute, then we just can't get rid of enough urea to even survive. Urea is the main nitrogen-containing waste in the urine, and we'll see that again coming up later on when we look at urine composition. But if you have GFR that's too low, urea accumulates in the blood, and that's toxic, uremia. It's fatal relatively quickly. So what are we going to do? Well, if someone has such severe kidney problems that they're getting uremic, we'll need to treat them with dialysis. And here, in this case, we're talking about hemodialysis. That means attaching the patient to a machine in which the blood comes right out of the body into a machine. And we'll place that blood in juxtaposition to a membrane across which dialysis can take place, right? The movement of solutes along their concentration gradients into a large volume of buffer that's in that machine, just a salt solution. And we can let the waste products from the blood diffuse over into the buffer in the machine, and then the blood comes back into the body. So we get rid of those wastes and bring the blood right back into the body. Unfortunately, hemodialysis is pretty rough going on the patient, plus there's usually some other complicating factors in the health of the patient. Mean lifespan once dialysis starts is around 5 years. Kidney transplants are the other main way to handle kidney failure, and what you may be surprised to learn is that when someone gets a kidney transplant, that's not a permanent fix. Kidneys only last for, on average, 10 to 12 years. Eventually, the kidney will be damaged by the immune system, and maybe whatever disease state killed the original kidneys is now going to act on the new kidney and cause slow degradation of its function, and then we'll have another example of kidney failure around. There's another type of dialysis, actually, that's interesting. If a particular port is placed through the abdominal wall, a saline buffered solution can be pumped or injected right into the peritoneum. Large volume of fluid can be accommodated easily in the peritoneum, with all that fluid just sitting there in contact with all the blood vessels of the digestive tract, the membranes that carry the blood vessels to all the lengthy intestines and so forth, the peritoneal membrane. Diffusion will take place there too, and then we can pump that fluid back out of the peritoneum along with all the waste products that diffuse out of the blood, and then inject another batch of saline solution into there, and we can accomplish dialysis that way. It's much less invasive than hemodialysis in some ways, but it's another strategy for replacing kidney function. All right, how about kidney character or urine characteristics? Urine is normally clear. It'll have color, but it'll be clear. If there's a cloudy look to the urine, that could mean there's something precipitating there. Some people that take a lot of dietary supplements, maybe for the purposes of bodybuilding or other athletic pursuits, may have something precipitating in the urine. When you look at it, looks cloudy, could indicate a urinary tract infection. Normally, the urine has a yellow color. That's because of hemoglobin breakdown products, right? Hemoglobin is converted by macrophages to bilirubin, which is taken up in the liver, placed in the bile. Bile goes out into the intestine to be gotten rid of, to be excreted from the body. But some of that material is converted to a yellow-colored compound by bacteria, and some of that in turn is reabsorbed back into the plasma and then winds up in the urine. So that's the yellow color of urine. The more concentrated your urine is, the more dark yellow it looks. So if you're dehydrated, you have plenty of ADH in the blood, and you're reabsorbing a lot of water, the urine will be very concentrated and will look dark yellow. There are situations where the urine may turn a dark brown color, for example, and that's a sign of certain drugs can cause that problem, or certain disease states can cause the urine to turn a dark brown color. So analyzing urine has a lot of diagnostic value clinically, and so you would, if you were studying certain types of clinical specialties, you would know how to identify all those urine issues. Odor of urine, slightly aromatic. That's not particularly informative. That just means it has an aroma. Yeah, it does. But if it starts to smell like ammonia, and if you don't know what that smells like, get some ammonia cleaner out of the cleaning cupboard and smell it and see what it smells like. And you'll find out what that ammonia smell is, and you'll probably recognize it. Anyway, if there's an ammonia smell, that might be due to bacterial action on urine that's been standing around. You could actually have ammonia produced in the urine by certain pH imbalances. Some vegetables. It's not coming to me. Asparagus is notorious for creating an unusual aroma of the urine. Other characteristics, we learned in lab that the pH of the urine can vary widely from, say, pH 4.5 to 8, because the intercalated cells in the collecting ducts of the kidneys and other cells in the proximal tubule, their job is to control the pH of the blood by either secreting hydrogen ions or bicarbonate, and those substances will change the pH of the urine. So the urine can vary quite a lot as the kidneys do their job keeping the blood pH neutral. Specific gravity is just a measure of the total solute concentration in the urine, and water has a specific gravity of 1.00 because specific gravity is just saying what's the refractive index of water that has solutes in it compared to pure water. So as you add solutes to urine, it changes a light kind of refracting property of urine, and we can use an instrument called a refractometer like we did in lab to figure out the specific gravity, which again is a measure of the concentration of the urine. The higher the number, the more concentrated the urine is. Some other composition aspects, nitrogenous wastes. I'm bringing this up because a quick way to establish or analyze, besides learning about GFR, the health of the kidneys, the function of the kidneys, is to look at the nitrogenous wastes that are present in the urine and in the blood. So the kidneys are supposed to remove urea, for example, from the blood. There's usually a little bit of urea in the blood, but most of it is going to wind up in the urine, probably about 85% of it as the blood passes through the kidneys. So that's the major nitrogen-containing compound in the blood, or in the urine, I'm sorry. And we said that if it's in the blood above a certain concentration, it's toxic. So kidneys need to get that out. It's one of the things we'll find. There's other nitrogen-containing compounds, uric acid, which comes from nucleic acid metabolism, nucleotide metabolism, and creatinine is a metabolite, as we said, of muscle creatine. So those are nitrogen-containing compounds, and we can measure all nitrogen in the urine by a special chemical reaction test, and we'll call that blood urea nitrogen. So it's just a classically used test to look at the total amount of nitrogen, and if the amount of nitrogen is going up, it pretty much means there's more urea accumulating in the blood. It's a sign of declining kidney function. So if you order a panel of blood analysis from the lab, one of the things you'll see on there is blood urea nitrogen, and if it's higher than normal, you can bet that the kidneys are struggling. Another way, just looking at the creatine level. If the creatine is higher than it should be, it's not being gotten rid of from the blood, even though creatine isn't the major nitrogen-containing compound. We know what the normal creatine level is, and if it's higher than it should be, then the kidneys aren't doing their job. Other components of urine, electrolytes, sodium, potassium, phosphate, sulfate, calcium, magnesium, bicarbonate. Why in the world would we find all those things in the urine? Well, because they're taken in the diet. Every ion that's taken in the diet has to be excreted from the body one way or another, because the body must remain constant in its amount of sodium, its amount of potassium, its amount of phosphate, and so forth. So whenever we take in those things, which we commonly do in our food, even calcium, right? We need calcium, but if we take in a lot of extra calcium, it's going to be peed out. We have regulatory mechanisms to control those ions in the body, right? Parathyroid hormone helps us control the level of calcium in the plasma. Aldosterone helps us control the amount of sodium and potassium in the plasma, and so forth. So, what else could we find in the blood or in the urine that would be abnormal? Proteins. There's no blood protein in the urine for the most part. Tiny bit. There's a threshold that's allowable, but there's only very little protein, right? Because the capillaries of the glomeruli, like most capillaries, like all capillaries, prevent plasma proteins from being filtered. And in certain kidney diseases, the plasma proteins may start escaping into the urine, and now we're going to have problems because we won't have enough plasma protein to hold the water in the capillaries, and we'll have severe edema. What else? White blood cells and nitrites might be a sign of urinary tract infections, as we've said when we analyzed our urine in the lab. All right, we have some more components of the urinary system than just the kidneys, which is all we've studied so far in terms of anatomy. The ureters are muscular tubes that carry the urine from the kidneys down to the bladder, and they are retroperitoneal, as are the kidneys, meaning that they're not within the peritoneal membrane. They're posterior to it, along the surface of the abdominal wall. And so the ureters carry that urine down into the bladder. Now, as we'll see in a little bit later in a picture, the ureters attach kind of to the posterior inferior surface of the bladder. So as the urine begins to fill up the bladder expands. It's sitting right on those openings from the ureters and kind of squashing them down and closing them off. So there's not back pressure from the bladder pushing back into the kidneys through the ureters. The ureters have, again, some smooth muscle in the wall. They can undergo peristalsis, a movement of fluid from the kidneys down into the bladder. If the bladder starts building up pressure, the ureters can force the urine down into the bladder through a wave of contraction called peristalsis. The mucosa just refers to the epithelium of the bladder, right? It's a transitional epithelium, and under that is some areolar connective tissue. That's the mucosa. And then the adventitia is an outer fibrous connective tissue covering where the ureter is against the abdominal wall. Here's a little picture, a micrograph of part of the ureter in cross section. We can see that right now it's empty, and so it's all kind of scrumpled up, shriveled up, and this purple sort of band here layer is the mucosa. That's the transitional epithelium. We have some smooth muscle and an outer connective tissue layer, adventitia. Kidney stones. Here's a homeostatic imbalance of some trouble. Kidney stones are precipitates that form in the pelvis of the kidney and in the calyces of the kidney, and they start to travel down into the ureters, and they cause just excruciating pain as they scrape up against the epithelium of the ureters. The ureters normally have nothing but fluid in there, and so the sensory neurons there are extremely sensitive, and when they're attacked by something solid, they're very, very upset, and you'll have severe pain. If they get big enough, they can actually block the ureter, and then urine does back up into the kidneys and causes severe pain. It's a very, very painful condition. Kidney stones are often made of calcium phosphate. If there's too much calcium and phosphate in the blood, some people have a hard time metabolizing correctly calcium and phosphate. An insoluble precipitate may form kidney stones. Calculi. A calculus is just another word for a precipitate. Sometimes kidney stones contain a lot of cholesterol. If someone has a dyslipidemia, meaning they have an abnormal amount of lipids in the blood, that can wind up causing a certain type of kidney stone. So, and also not to mention gallstones in the gallbladder. So what can we do about it? Well, the main thing that's usually done is to an intravenous infusion of a Ringer's solution, meaning a balanced salt solution that's isotonic, but it'll greatly increase the plasma volume temporarily, which will hugely increase the filtration rate in the glomeruli, a huge increase in urine flow rate, and that will hopefully be enough to wash those kidney stones right down out of the ureters and get rid of them. But if they won't come out, if it's too big, ultrasound waves can be used to actually break up the stones. The bladder. The bladder is a muscular organ, and it's also retroperitoneal, sitting on the pelvic floor muscles. And let's take a look. We'll see some graphics that illustrate how the bladder and the urethra are situated in the body. The tridone is just the name of the area on the inferior part of the bladder, a triangle formed by the urethra going out and the two ureters coming in. They're very near each other and they form this little triangle area. It's a place where if there's an infection that does become established in the bladder, this area is the hardest to rid of an infection, the trigone. The bladder, again, has a lot of smooth muscle in the wall. That smooth muscle in the wall of the bladder is called the detrusor muscle. There's a lot of muscle there, right, to squeeze the urine out. When the bladder is empty, it collapses. It has basically almost no volume in it, much like the stomach, and it forms ridges as the surface, the mucosa gets scrumpled up. They're also called rugae, little folds in the mucosa. When it's full, it can hold upwards of 500 mils or more. Once you get to 500 mils, you'll start experiencing some serious urgency to get rid of that urine. In emergency, it can hold twice that volume, but eventually it can burst if there's an inability to let the urine out of the body. Here's a special kind of a contrast enhanced image. There's iodine and contrast medium has been injected into the blood, and this X-ray has been produced where we can see the iodine is going to be excreted in the urine, so you can see the calyces and the renal pelvis, the ureter, and the urinary bladder here as the iodine begins to accumulate in those structures. So that's pretty cool. It's a way of looking. What if there's a blockage in here? If there's a kidney stone blocking a ureter, all of a sudden it'll be blank further down that ureter, and that's a way of assessing where is the kidney stone and what's it doing. Is it causing a blockage or just pain? Here's a cartoon illustration of the bladder, the trigone, this little triangle area here, and the bladder doesn't have flaps here. They've just shown how it's been kind of cut open and peeled back to show us inside. The urethra is the passageway through which the urine will leave the body. So the urethra has three parts to it in this picture of the male urinary system. The prostate gland, we can see here surrounding the urethra, so that's called the prostatic urethra. Then there's the intermediate part here going through the abdominal wall, the muscular wall, the floor of the pelvic cavity, I should say. And then the spongy urethra is coming through the penis. So those are three parts of the urethra in the males. In the female, the urethra is much shorter. There's this short little passageway to carry urine out through this, again, the muscular floor of the pelvic cavity and then outwards. The urethra opening is situated between the vagina and the clitoris. So, what's the lining of the ureters? Pseudostratified columnar or transitional epithelium. How about the urethra? Urinary bladder has a transitional epithelium. Urethra has pseudostratified columnar epithelium. There's a transitional epithelium near the bladder, but then it morphs over into pseudostratified columnar epithelium. On the skin on the outside of the body around the urethra is, of course, stratified squamous epithelium. So that kind of penetrates a little bit down into the urethra. There's two muscular rings around the urethra that control the movement of urine out of the bladder. The internal sphincter, it's called, this ring of muscle, is smooth muscle, and it's controlled by the autonomic nervous system. And then the external ring or sphincter is skeletal muscle that has voluntary control. That's how you can control the timing of urination or micturition. All right, we already talked about the location of the external urethra, the orifice between the vagina and the clitoris. The male urethra is much longer and has these three different regions to it. We've already seen that in our cartoon picture. We looked at just exactly this cartoon right here. Micturition is the process of voiding the bladder, getting the urine out of the bladder. There's three things that have to take place. We have to open up both sphincters, one by an autonomic reflex and another by a voluntary relaxation of the external sphincter, and then contraction of the detrusor muscle, another autonomic reflex that will push the urine out of the bladder. Sometimes urine comes out of the bladder unwanted. That's called incontinence. I'm sure you've heard of that. If there's urine dribbling out of the bladder throughout the day, that can be a very difficult, socially paralyzing kind of a situation, and requires certain specialized kinds of absorbent garments that will prevent the urine from coming to the surface and have to be changed regularly. So this is a big problem in a very large number of people, surprisingly. So if there's this inability to maintain the seal, the sphincters can't hold the urine in all the time. That's called incontinence. There's a number of physiological maladies that lead to incontinence. Urinary retention. After general anesthesia, many patients have this problem of inability to void the bladder, and so they'll have to be catheterized. A plastic tube inserted right through the urethra into the bladder so that the urine then just can travel freely out of the body, and that urethra, or that catheter, will be attached to a little bag on the side of the patient's bed so we can observe the urine flow rate and see what the health of the kidneys is. Even simpler than measuring GFR, just look how fast that urine's coming out, and an experienced clinician will know whether that rate is normal or not. UTIs, urinary tract infections, are quite common in women because they have the shorter urethra. It's much more likely that bacteria, which are all over the skin on the outside of your body, can find their way up through the urethra into the bladder and colonize the bladder, and eventually maybe even move on into other parts of the urinary system. So that can be a very painful and uncomfortable experience, and it also can be life-threatening if it becomes severe enough. So UTIs are actually a common outcome of catheterization. We said that catheters are often used to help with micturition after general anesthesia. Well, many women especially, but many males as well. When you stick a catheter right into the bladder, then infections often ensue. When an infection gets into the urethra and becomes inflamed and uncomfortable, that's called urethritis. Itis, remember, is the suffix that means inflammation. If the bladder, an established infection in the bladder, is called cystitis. Pyelitis, getting all the way up into the calyces and the pelvis of the kidneys. When the nephrons get inflamed with infection, that's called pyelonephritis. That's a very serious condition, a life-threatening condition right there. Intravenous antibiotics are going to be required in order to get that under control. And again, some women are prone to bouts throughout their lifespan of pyelonephritis occasionally. If the urinary output is so low that there's no hope that the kidneys can help get rid of the important waste such as urea from the blood, that's called anuria. Anything less than 50 mils in the entire day, it should be around a liter, 20 times that, then we have anuria, not urine. That could mean that there's not enough blood pressure. If someone has congestive heart failure, the blood pressure is so low in an emergency situation, you need a certain threshold of blood pressure to be able to make filtration happen. Below that hydrostatic pressure, it doesn't happen, and there's no urine formation. Various kidney diseases can produce anuria. So when the kidneys can't filter, then we have a problem. We can't produce enough urine, and the body's in serious trouble. The reflex for urination, as the bladder stretches, that activates stretch receptors that produce a sense of urgency for urination. And once the decision is made, then the external sphincter can be relaxed, and it's a parasympathetic autonomic reflex that opens up that internal sphincter and causes contraction of the detrusor muscle. It inhibits this reflex inhibits sympathetic pathways and activates parasympathetic pathway, which allows this process to take place. The control centers for this reflex are in the pons. That's why the pontine is just an adjective of the pons. So there's a micturition center in the pons that allows that reflex to take place. The ability to hold the urine, the pontine storage center, which has sympathetic neurons, which contracts the internal sphincter, and the pontine micturition centers mature between ages 2 and 3. And that's when we expect to be able to potty train, quote unquote, our children, because that's when they become able to handle this aspect of their body functions. And so just this final summary slide, you can look this over, all the aspects of stretching the wall of the bladder and the reflexes that take place, inhibition of sympathetic nervous system activity, activation of parasympathetic reflex in the pons, contracts the detrusor muscle with micturition. So the part of the higher brain center, that's important for relaxation of the external urethral sphincter, and we can get that urine to come out. So that's our story as far as wrapping up chapter 25. Join me next time for chapter 26, where we learn a little bit more of the overall summary of how the kidneys help control the fluid volume in the body, the concentration of various solutes and electrolytes, as well as the blood pressure.